Welcome to Plastic Surgery TNA. This is an episode titled Anatomy of a Case, and we're going to talk about breast augmentation and breast lift at the same operation. Hi, my name is Earl Stephenson Jr. I'm an Atlanta board certified plastic surgeon, and I'm your host today. And I want to bring this to you because I want to spread truth and transformation and debunk myths in plastic surgery and beyond. So, without further ado, those who are new to the station or new to the channel, thank you, thank you, thank you. Those who have seen me before, I really appreciate you returning. And I want you guys to share who are returning, share this video. And those of you who are new, and if you like it, I want you to subscribe. So, subscribe to my YouTube channel. This is where all the episodes are. And I have additional videos about all things plastic surgery that would be of great interest to you. So it really helped me if you subscribe, help build the channel. I can do bigger and better things, bring on bigger and better guests. I do have guests occasionally, and we really can take this thing to another level. So, on that note, let's get into it. I want to talk about breast augmentation and a simultaneous breast lift. It's a very popular, I think, popular um, procedure, but it's a very hard procedure. In my 20 years of experience, I think it's one of the more difficult procedures because if you think about it, you've got a woman who's got a breast that's deflated and droopy. And what she really wants is a breast that's inflated and perky. So, how do you solve that? You solve that by inflating the breast with an implant. So, you're making it larger, but you're talking about a breast that's also droopy and you lift it by making it smaller and tighter. So, you've got two competing forces. And that's very, very difficult to strike a balance. So, we're going to talk about today a couple of things of how to best strike that balance. One, we're going to talk about the causes of droopy breast, medically known as breastosis. That's our $1 million word for today. Breastosis equals droopy breast. We're going to talk about the causes. We're going to talk about how you can recognize yourself if your breast is droopy and may need some type of intervention. We're going to talk about the types of intervention. Are there non-surgical solutions? If so, what are they? Are there surgical solutions, of course? And if so, what are they? Talk a little bit about the nuances of surgery. We're going to talk a bit about the recovery. We're going to talk about the incisions that are involved in surgery, how to care for those. We'll talk a little bit about the types of implants, when, where, and why to use them. And then we'll finally wrap this up and put a big bow on it by showing you one of my cases. So we can be critical. I can be self critical. You can be critical and tell me what you think. So, again, without further ado, let's just numerically and verbally go through this. What are the causes of loss of breast volume and breast droop? The first one is really simple. It's just getting old. We all get old. And as we get older, our skin gets a little less elastic. The ligaments that are tight and keep things firm get a little droopier or looser. And so that leads to a woman's breast going from here to here, just simply by getting older. And it's really nothing we can do about that. The second cause is what, again, one would think ladies want to have families more times than not. And so with pregnancy and breastfeeding, the breast gets really full in anticipation of the birth of the baby in preparation for breastfeeding if the woman decides to, or if nature decides to allow the woman to breastfeed. But the breast nonetheless gets engorged. And so it stretches out that skin, it stretches out those ligaments. And as the woman breastfeeds, or naturally the breast kind of shrinks back because it's not being used in that manner, then that skin that was stretched, those ligaments that were stretched, don't recoil back tightly. And if you do that a couple of times, they just flat out droop and the breast deflates. So, aging coupled with breastfeeding and pregnancy are two causes of loss of volume and a droopy breast. On that same note, with a breast that gets full and gets smaller and gets full and gets smaller, you have weight get loss and weight gain or fluctuations in weight. So if you kind of are yo-yoing with your weight because of diet and can't find that consistent balance, or you've gained a significant amount of weight and have carried that weight for quite some time and decide to have some type of intervention, whether that's through a medical means like with injections with Ozempic or Wegovy, coupled with exercise, or even surgical intervention with a stomach stapling or a gastric sleeve, coupled with exercise, then you're going to have a breast that was once full. And now, with that significant weight loss, is going to be deflated and droopy. So that's the third cause. The third cause is weight fluctuations. The fourth cause is a combined cause. It's genetics and gravity. So, genetically, if you have a lineage that women over time just get droopy breasts because of weakness of their skin and the ligaments, then there's really nothing you can do about that. You know that's coming. If you don't support your breasts, no matter what size, but certainly if they're heavy, that weight of the skin, the breast tissue, the fat along with the breast tissue will, without support over time, stretch those ligaments, stretch that skin, and you'll end up with a droopy breast. It may be fuller, but it may be droopy. But with age and non-support, and age and non-support, and pregnancy and breastfeeding, you will then also lose volume. So again, the causes are aging, pregnancy and breastfeeding, weight fluctuations, gravity, and genetics. So now you know the causes. You can't do anything about aging. You can't do anything about genetics. You can decide not to have a family. You can decide to maintain a steady weight, or you maintain a steady weight despite all the things that you do. So those are things that you can have control over. Nonetheless, no matter how you get there, when you have a deflated, droopy breast, either you're going to accept that or want to do something about that. So, how do you know if you should make a step to call a plastic surgeon's office? What can you do in the bathroom at home or in the mirror in your bedroom to see if you kind of pre-qualify yourself for a droopy breast? Obviously, you can see that your breasts were at one point when you were younger or before you had your family, they were here and now they're there. But what objective things can you point to say, yeah, my breast is droopy? So we as plastic surgeons have a grading system for breast droop or ptosis. It's a little nuanced. It's a grading system, 1 through 3 to 4. I tend to use more of a esoteric. Is it mild or moderate slash severe? So let's pop up this slide, and this will give you a pictorial representation of breast ptosis or droop. Okay, so what we have here are three illustrations, A, B, and C, and that's not the cup size. So get that out of your head. A represents a relationship between a couple of portions of the breast that are critical in determining if you have true breast ptosis or droop. One is the nipple, one is the natural breast crease underneath your breast, and I'm going to add a third. It's that tissue between the nipple and between the crease. So, in a normal, and I hate to use that term, situation for a woman's breast, the nipple is above the level of the crease, or at least at that same level. The breast tissue between the crease and the nipple is s- of moderate size. So, nipple is at the level of the crease or slightly above. That is a typical or quote normal situation. When you go to illustration B, this is what I would call mild ptosis or mild droop, where the nipple is slightly below that crease. The fold or the breast tissue between that nipple and crease also is a little bit lower, but it's lowered at the same level as the nipple. It's not disproportionate. So the nipple's a little lower below the crease, as is that breast tissue between the crease and the nipple. Illustration C represents further droop of the nipple significantly below the crease, in addition to the breast tissue between the nipple and the crease. So this is classified in my world, in my mind, as moderate to severe, depending on how much it is below the crease. And for me, that's again a little bit nuanced. Someone comes in, they're way below the crease, and someone may come in the same day and have something significantly below the crease. Again, moderate to severe. And I just grade it accordingly. And with that grading system, you can look at home and say, yeah, my nipple is below the crease. If I really want something done, I'm probably going to have to seek the opinion of an expert or board certified plastic surgeon. But I want to give you a caveat too, because I want you to remember what we kept talking about is that tissue between the nipple and the crease. You can have something called false ptosis, or again, the $1 million word for that is pseudotosis. So let's remove this and let's pop up this. Here we have figures A and B. One is pseudotosis and the other one is glandular ptosis. To me, they're one and the same because what's happening is that the nipple is at the level of the crease or above in both cases, but the tissue between the nipple and the crease is relaxed or droopy or saggy. And so that tissue represents typically breast tissue and some fat. So that's gland that's sagging, so glandular ptosis, or it's not, it presents almost, if you look at it visually, like your breast is droopy. Well, the nipple's not droopy, but the breast tissue is. So that's pseudo or false ptosis. So again, splitting hairs here on the terminology, you just got to recognize as the plastic surgeon for sure that the nipple position is pretty good. And so you don't really want to alter that per se, but you want to alter that tissue that's between the nipple and the crease. So that's really important for us to recognize. And it's a good little tidbit to put in your back pocket to recognize as well as the patient or client, even before you step in a plastic surgeon's office. Really, from your standpoint, that's all a client really needs to know, whether they should seek an opinion. Now, of course, you want to make sure that you're healthy. You want to make sure that you don't have any history of breast problems, either benign or cancerous, of course, or have a family history of that. If you do, you want to make sure that you have all those records and all that information in hand if you decide to move forward and seek expert opinion in the plastic surgeon's office. If you decide to go to the plastic surgeon and seek the consultation, it's important that you see a board certified plastic surgeon. And how do you best do that? You simply get on the interwebs and you type in this web address and you go and you find a place for you know patients, probably at the top, and they'll ask you to type in the particular doctor's name. You type in the doctor's name, they'll tell you if he or she is board certified and where they're located. Obviously, you'll know where they're located because you've already done that legwork, but you can see if they're truly board certified by the American Board of Plastic Surgery. There's no other board for plastic surgery. Plastic surgeons do aesthetic or cosmetic surgery, and some of us combine that with reconstructive or functional surgery. Some of us just do reconstructive or functional surgery, but we are all trained in aesthetic or cosmetic surgery as well as reconstructive surgery. That's why we have the greatest depth of knowledge to take care of all things, as opposed to a cosmetic surgeon, in my opinion, who doesn't really understand all the nuances of putting things back together when they're just toe up from a reconstructive standpoint, like an abdomen slash tummy, or like a breast, or like a face when they're doing their facelift or their tummy tuck, because sometimes things just don't go the way they're planned. And you need to know how, as the surgeon, to work through that. And having those principles of rebuilding and things gives you and gives us the feather in the cap that you need as the client to make sure that you have the safest outcome. So that's that. Make sure you see your board certified plastic surgeon. So when you do, you may ask your board certified plastic surgeon, is there anything that they can do short of surgery? And the answer, it's going to be no. But it's funny, if you get on social media, and a lot of you will do this prior to your consultation, but if you get on social media, you'll see all kinds of things to do non-surgically to lift your breast. And I got on and I just picked out 3 videos. There are a million that I'm just going to let play. And we're going to discuss really briefly before we get back to what your plastic surgeon will see on his or her examination to give you the right recommendations for your breast droop and lack of volume. So let's pull up the first video. So here we go.
It's nothing. Balling. Alakwa. Premium or nothing. When them or nothing. Now you know.
Okay.
Now you know.
They're
Now
doing
you
thread
know.
for this lady's excess breast droop. And those threads will be kind of placed and the breast will be pushed up on the thread. Threads have little barbs on them, much like fishing wire. And so you put the thread into the breast, you catch the tissue underneath the skin, and sometimes you catch the skin, and you don't really want to catch the skin, but sometimes you do, and you just gather that breast tissue along that stitch, and those barbs engage the stitch and keep the breast up. And hopefully that will scar in that position, but you don't do anything about the the excess skin. You have to take care of the excess skin when you lift the breast. It doesn't address the volume really to any significant degree at all. It may bring some of the breast tissue up, but if you have just not a lot of breast tissue to begin with, you're just moving it up and not really augmenting or adding to. So if you're thinking about having a thread lift for your breast lift, just don't do it. Thread lifts really have the popularity in the face, and I would even do it for a face. Again, these opinions that I'm going to express are mine only. These are typically done or performed by non-surgeons. Let's just say that. Non-plastic surgeons specifically, because they, one, either don't know how to do a breast lift, two, can't do a breast lift because they can't go to the hospital or any type of surgery center to do a breast lift. And so they get you in the office and they lure you in because it's non-surgical, no downtime. You can lift your breast, you can go home the same day, wear your fabulous dress, and you're off to the races. Those things are all true, but you won't have the results you want. And you'll be back in my office or one of my colleagues' office paying more money to have a real breast lift and probably an implant. So Don't do a thread lift. So that's one I found. So let's take that one off. Let's look at the next one. I'm gonna let that run again from the beginning. So here we go. We're gonna run that from the beginning.
This is how we do
She's marking the upper pole, the upper part of her breast. This injector is injecting sculpture. Stop it. She's injecting sculpture. Sculpture is a filler, just like a filler in a sense, like Juvederm to fill lines along your nose and mouth or lower jaw or even your tear trough. But it's different in a sense that Sculptra will actually stimulate the body to fill in or produce collagen to add volume. It's historically has been great in the cheek area for clients who have really sunken in or hollowed cheeks, typically from HIV disease. So it works really well in that population. It works really well for people who are really emaciated, hollow for whatever reasons besides HIV in that area. It's a small area as compared to the breast. So if you get this placed in your breast, you've got to put a significant volume in, and you don't really have a lot of great control of all that volume. You don't know how much collagen is going to be produced in one area versus the other. You don't know if it's going to be the same from breast to breast, even though you might have put in the same amount or amounts that you thought were appropriate for each breast because of size differences. There's so many things out of your control with just injecting that. And then on top of that, sculpture is fairly costly per vial, and it's going to be more than one vial. I'm assuming I don't do this, but more than one vial for each breast. So you're going to spend good amount of money trying to get this done as a non-surgical, process. So it's no need to really even do that because, again, being in this game for 20 years, I think I have a great sense and I know what clients want. And clients have a thought in their mind of what they want and the outcome that they see. Sculpture is not going to get you there. So don't waste your time with that. The last one is just, I wouldn't say hilarious, but it's just interesting. It's born off of a different concept. It's a really quick video. So I'm going to probably not let it even run through all the way. I'm just going to stop it in the middle and try to explain. So here we go. This is the last non surgical one. Okay. So these are vacuum pumps sucking on this lady's breast. I mean, it is what it is. This is meant to cause, is actually meant to cause extra skin and space inside the breast so that you can fill the breast with something, fat typically. So when women really wanted a significant volume of augmentation and they didn't want to have an implant and they wanted to have fat utilized and they wanted to get good volumes in, then they would have this suction device placed on for a period of time, several several weeks before they had the actual fat grafting surgery so that there would be space created so large amounts of fat can be placed so that you have a significant breast augmentation with fat. If you didn't do that, then the breast tissue itself, if it's very small breast, you couldn't put a ton of fat in to make a significant difference. You would definitely have to come back multiple times to build on that fat. This gives you more space to put more fat in one operation. So that's traditionally what it's used for. It certainly, in my opinion, has no place for breast lift treatment and breast augmentation treatment in combination. It's just not a good idea. So don't waste your time on that. So the only real non-surgical solution is what you ladies have been doing for eons. You get a good bra, and you get a good support. You lift the ladies up. Maybe you stuff one versus the other to kind of even things out, and there's your non-surgical breast lift. And that's what you either decide you're going to do forever and a day, or you get tired of it and you want to do something else and you pivot into the plastic surgeon's office. And here we are. We talked about the non-surgical nonsense that is not a issue, that's not treatment for anyone. And we just got to get down to what can I do for you surgically? Because that's going to be the most predictable and have the most longevity. So we talked about the examination when you're at home. How can you look at your breast and tell whether you have mild, moderate, or severe ptosis? We do the same in the office. We look at those landmarks, those structures on your breast to determine that. And then we also kind of quantify that with measurements. We measure from the top of your sternum down to your nipple for each breast. We typically, if we say a normal measurement would be in the 20s, 22, 23. We measure the width of your breast so that we know how, if when we're using an implant, how big of an implant we need to use. We want to make sure we use one of appropriate size. One is not too small, one is not too wide. We want to measure the distance between the nipple and the natural fold because that distance is typically long, especially in moderate to severe breast droop or ptosis, and we want to shorten that distance. So those are three critical measurements. We also want to examine the breast for masses or lumps or bumps, soreness, discharge. We want to look at the quality of the skin because the quality of the skin has been kind of compromised either from the things we talked about: weight gain, age, pregnancy. So when we put an implant in, we got to put an implant in that's the appropriate size, not too heavy, but gives you the shape you want and one that the skin can support long term. So we want to look at the quality of the skin. Once we've done that, we either decide that we're either going to put in a saltwater implant, which is a saline implant, or we're going to put in a silicone implant. Implants have gotten a bad rep over many years, some of it deserving, but implants are one of the most steady medical devices in history. And so their safety profile is pretty darn good. Each surgeon has his or her preference as to why they use saline or why they use silicone. I like saline. Saline comes in a form of an implant that's flat, doesn't have anything in it. I can place it, I can fill it with salt water. And the beauty of it is that if I get a 300 cc saline implant, meaning I'm going to fill the implant at least the 300 cc's. Mentor is the manufacturer that I use and I like. Gives you some variation in how much you can fill that. So we got a 300 cc implant. We can fill it maximally up to 350 if we wanted to. So if I have breasts that start out uneven, we have a smaller breast, I can put 340 cc's in that breast. And in the larger breast that doesn't need as much, I can put the minimum 300 and even things out from a volume standpoint. And then because I've done my measurements, I know I want to lift the breast back up to a level of 22, 23, 24 centimeters. I know how much lift I need, and the incisions that I choose will determine how much I can lift the breast. So, with my clients, I make the decision of saline or silicone implants. I Most clients ask me what I think is best and what works well in my hands and what would give them a natural result. If they ask me that, then I will lean towards saline. If they are really, really adamant about having silicone, I'm fine with that. I just know I can't adjust the implant and I may have to adjust the tissue, meaning in the larger breast, I need to take out more tissue and not take out any tissue in the smaller breast. So there are ways around that as well. But we also talk about the incision because no woman likes an incision on her breast. And there are three incisions that are typically used for a breast augmentation and lift. So let's look at those. Let's pull up those incisions. All right. The first one is a donut lift. And it's just like it sounds. It's a round lift around the areola. Let me see if I pull up the right illustration. Whew, I did. Fantastic. So this is a donut lift. It is just like it sounds. It goes around the areolar, the natural areolar that's really wide. And then we put an inner circle inside the areola of the diameter that we want. The two circles are there. We take out the skin between the two circles, the inner circle and the outer circle, and then we cinch the skin together like a purse. We drawstring it together and we can kind of lift the nipple at the same time. Not very far, but 1 to 2 centimeters. 1 centimeter to two is probably about that much. And we can also place our implant. Some plastic surgeons will place the implant through this areolar incision. I don't like to do that because it's technically too difficult. And I don't like going through the breast tissue to put an implant, which is a foreign body. And breast tissue naturally has bacteria, and that's natural to all breasts. And I don't want the implant to be kind of coated in bacteria. I just don't. So what I do is I make a little incision in the crease, place the implant underneath the muscle partially. I like to do a dual or two plane pocket. The majority of the pocket is made up under the muscle, and the remainder of the pocket is made up by the breast tissue. So let's say 2/3 of the implant resides underneath the muscle and 1/3 underneath the breast tissue. And that gives me the volume I want. And I do my little donut lift to lift it a little bit and to resize that areola. That's perfect. So a woman who comes in with her measurements that are 25, 26, she's got mild ptosis, the nipple is just below the crease, then we may be able to do this type of procedure to get her the shape and size that she wants. If her nipple is below the crease a little bit more, we may need to opt for another type of incision, which is the lollipop incision. Well, that's not the right one. So let me get to the lollipop incision, which is the lollipop incision. Same principle. We go around the areolar and then we go down the center of the breast toward the crease. You can put the implant in through this incision in the middle. You can kind of sweep the breast tissue out of the way and get underneath the muscle without going through the breast tissue with the implant. So I've done it that way without making an additional incision in the crease. It's a nice incision. It shortens the incision. There's no incision in the crease of the breast. It reduces the size of the areola. We place the implant like we talked about in the first example, in a dual plane, and we lift and shape the breast. I used to do this a lot when I was beginning my career. I don't use this incision whatsoever at all now. And this is why. I would do just as I explained. I would place the implant, I would do the lollipop lift. And at the bottom of the lollipop lift in the crease, you would see all this kind of bunched up tissue. And all the gurus at the time were saying, oh, this will shrink back. You'll never see it. You got a short scar. It's all good. No, it didn't. It never shrunk up. It was a mound of tissue underneath the breast that irritated the heck out of the patient. And I ended up more times than not in my office numbing that area up and taking out that wadded up tissue in the crease and creating a smiley face crease incision. And so if you have a smiley face crease incision, a lollipop incision combined, that's an anchor incision, which is the last incision that I want to talk about, which is this incision. And so, with that being the case, I stopped doing the lollipop because I ended up with an anchor or inverted T type incision. So, when clients come to me and they have significant droop, moderate to severe, we talk about placing an implant, as we talked about in the other two examples, but we use this incision. I use this incision because I'm going to end up here. And it's the most powerful incision. It allows me to shape the breast as far as width and projection. It reduces the areola, so it really has a lot of power. But again, clients, women worry about incisions on the breast, and that's valid. The incision around the areola usually is not a problem. The incision in the crease is not a problem. It's the incision that's in between the two that can be the wild card. In women of color, that can be very subtle, where it's just a little faint line. It could be a little faint brown line, or it can be a really brown wide line. No matter the techniques, sometimes we end up with a little wide line, but more times than not, we end up with a faint brown line or just a faint line. Women who do not have pigmentation end up with a nice kind of white scar that goes down. Not an issue. In surgery with my clients, I make sure that when I'm performing this operation, that the incisions and the stitch lines are brought together very nicely and without a lot of tension and pressure, like they want to kind of just hold on to each other for dear life, because that tension wants to spread the scar, which ends up in a wide scar. So I use certain techniques to make sure that the skin edges come easily together, really light, really softly, and so that we have a nice scar. We're meticulous about how we handle the breast tissue. We're not pinching it, squeezing it, beating it up. We're not doing that, because that can lead to unfavorable scarring as well. After the fact, I am a big proponent, when needed, of use of medical grade silicone on the scars, because that softens and improves the quality of the scar, in my opinion. So we have tricks of the trade and methods to manage the incisions where they can heal very favorably. And I'm going to show you a case at the end, which I think illustrates that. So, more times than not, in my opinion, an implant with an inverted T or anchor type incision is going to be the one that gives the surgeon the most options to get you the results you want. Everyone's a little different. Your situation may be a little different, but 9 times out of 10, I think this is the way that most clients are going to need to go to get the shape that they want. So, we talked about the operation, how we do it, what incisions we're going to use. Let's talk about a little bit about the risk and complications, and a little bit about the recovery. The surgery length varies from surgeon to surgeon based on the experience. It varies based on the complexity of the case. It varies based on some unforeseen factors that may pop up. But I'm going to say, on average, the surgery takes me about 3.5 to 4 hours, depending on what needs to be done. It is an outpatient procedure. This is not something that you can do under local anesthetic awake in the office. Let me say that again. You cannot do this under local anesthetic awake in the office. It's ridiculous. Stop it. You go to the operating room, either at an accredited surgery center, either in office with your plastic surgeon, or your plastic surgeon takes you or asks you to meet him or her in an accredited outpatient for a freestanding surgery center, or at a hospital. And that's where this is performed. It's an outpatient. You get to go home. You have a recovery time in general over 6 weeks. We see you back in the office, depending on each surgeon's kind of process, to make sure that you're doing well. You can expect bruising and swelling, and that the incisions will look a little stark in the beginning, but over that 6 week period, and even over the next year, those incisions will soften. The breast will soften. The shape will soften. It is a tincture of time to get you where you need to go. But typically, 6 weeks, you will be back to your regular activity. You can probably drive, and everybody's a little different. Don't hold me to this. Drive within a week or two. You can get back to lower body exercises, minor to modest, in about 2 to 3 weeks. You can get back to full exercise, maybe not uh, pec exercise, but you can get back to full exercise minus pec exercise to in about 6 weeks. So you can get there. This is not something that you need to, you know, lay in the bed for 6 weeks, miss 6 weeks worth of work. You don't have to do that, especially with people working more remotely these days, post pandemic. You can actually sit up at your workstation in your home and get back to work least within 3 to 4 days, at least. So that's kind of the recovery. The risk, our general risk, there's a chance of infection, very rare. There's a chance of fluid collections around the breast. Sometimes I use drains in surgery if I think that's going to be a problem. The drains usually come out when the fluid output reaches about a tablespoon over a couple of days. Um, Sometimes you can have a slow scarring of the implant or around the implant that may take years called capsular contracture, but that's why we don't monkey around with the implant. The implant is placed immediately, sterilely out of its packaging. It's doused with antibiotic solution. It's placed immediately into the prepared pocket. Again, I don't like to put the breast implant by putting it through breast tissue to get to the pocket, so I reduce my contamination there. So we do all kinds of things to reduce contamination so that we can minimize that capsular contracture. So those are some of the risks and complications. So wrapping this up before we get to the case, this is a very satisfying procedure for our women clientele. From a surgical standpoint, it's a challenging operation because there's so many things that need to be adjusted because you have an operation that wants to give you volume, the implant. You got an operation that wants to give you lift and sizing that's smaller. That's the lift portion of the operation. So you have these two competing forces, and you've got to get everything evened out. So it can be a bit of a challenge, but with experience, there are many, 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 many plastic surgeons across this fine nation that can do this expertly. And that's because they have the experience, and that's because they have the training. And that's because we are continually vetted on this type of training and experience throughout our career through the American Board of Plastic Surgery. So on that note, let's look at my case. I often talk about what other people shouldn't do, and I wouldn't do that. Let's look at my case. Maybe you'll tell me what I shouldn't do. Maybe you tell me what I you don't like about my case. I encourage you to leave the comments below. So let's pull this up. So here's the anatomy of a case. We've kind of gone through the prelims. Here's the case. So I'm gonna need to take a drink of water. I'm thirsty. All right, here we go. We have this lovely lady who has done all the things. She's got a great partner. She's married. She has a great family, great kids. She's done with that. She's got a great career. All the things are in line. And now she's ready to enjoy all the fruits of her labor. And she wants her body to be in the best possible shape that it can. She exercises, she eats well, but she can't do anything about what time childbearing has done to her breasts. As you can see, she has breasts that are uneven. She has a nipple that's below her natural crease. And she has excess skin. Let me take another drink. Excess skin. And she has a deflated breast. So the if she wants improvement, she's going to need a breast augmentation and a breast lift. Now I've covered her nipples with this brown kind of pasty, but I wanted to leave the edges of the natural areolar so that you can see that in our result picture, the size of her areola. So I decided that, as I often do, patient's healthy, no medical problems, no breast health problems, mammograms have been normal, no family history. We're going to do a dual plane breast augmentation with a saline implant filling the breast on the right hand side of the screen, less than the breast on the left hand side of the screen. Let me say that in reverse. On the left hand side of the screen, that breast is going to get more volume in the saline implant, and the right breast is going to get, or the breast on the right of the screen is going to get less volume. I probably used about a 350 cc implant. I used 400 cc's on the breast on the left side of the screen, and I used 350 on the breast on the right side of the screen. Now, in this case, And you guys may have heard of this. I did not use an internal bra. I didn't think she needed an internal bra. You go, well, what's internal bra? You didn't talk about that before we saw this case. When I'm judging the quality of the skin and the implant that I've made place and how much weight and strain that skin is going to be going to have on it, then it may need a little extra help. It may need an internal hammock. Now I'm going to kind of come high. It needs a hammock like this to kind of support the implant so that the skin is not the only thing supporting the implant. And that's typically made out of some type of collagen substance, either human donated collagen. Sometimes it's bovine or cow, all safe and all dissolves and replaced by your own tissue. I did not think she needed an internal bra. So we placed the implant in the dual plane. I did an inverted T or anchor type incision, which we were able to reduce her areolar, lift her breast, and shape her breast. So let's look at the results. 3-month result. So bam, here we are. She was happy. I was happy. She still has probably a little swelling at the top that will resolve slowly over the next, let's say, 3 to 4 months. But overall, this is going to be her shape moving forward. I mean, you guys tell me. I mean, this is better, obviously, miles better than before. But you may have some comments. You may not like the size of the breast. If I'm going to be super critical, the breast on the left hand side of the screen that I feel a little bit more looks a little bigger to me. Maybe I went a little overboard. Maybe that's a little swelling. Time will tell. But these are the nuances on the table that, this looks even, but as time goes on, swelling goes down and it may reveal some subtleties that the breasts still aren't perfect. And our goal is never perfect, but our goal is much, much, much better. And I think she's much, much, much better. Again, the pasties are there. You can see the size of the reeler is reduced. She's got the anchor type incision. They're still healing and they're going to get better. The areolar incision looks pretty dang good. The vertical incision, the up and down incision, looks really good for 3 months. It's got another 9 months plus to get better. I think this is not going to be an issue for her. And the crease incision you can't see because it's covered by the breast. And as you notice, the nipple is at the level of the crease. So all in all, we've hit all the things that needed to be hit. We've increased her volume. We've decreased the droop by lifting the breast. We've improved the shape. She's happy. So if you have decreased volume, if you're unhappy with the position of your breast, or you're just unhappy with your breast and you've taking care of your family. You've finished your family plans. You want to look good when you wear a nice gown, when you go out with your plus one. You want to wear a bathing suit. Whatever the case may be, you want to do something for you to reward yourself, to feel good about yourself. And your breasts have been a problem for you, then you can always have a conversation with a board certified plastic surgeon. It doesn't take anything but your time to have that conversation. And at the end of that conversation, you may decide, I'm just going to stick with my bra and my padding until you don't. Or you may always stick with your bra and your padding. But if you want to improve your breast shape, surgery is the only consistent way to do that. So if you're interested in having it, I would love to work with you. I am certified by the American Board of Plastic Surgery. Again, if you're not in my area, even though I treat people outside of Atlanta, outside of Georgia, outside of the region, we do virtual consultations. But let's say you're somewhere that you have a great plastic surgeon that you like his or her work and you want to work with her, make sure they're certified by the American Board of Plastic Surgery, not any other board. Typically, their plastic surgeons are a member of the Aesthetic Society. I'm a member of the Aesthetic Society. I think it's a great society. It really helps me stay on the cutting edge of cosmetic or aesthetic surgery. So I'm a member of that society. Some plastic surgeons are a member of this society and the American Society of Plastic Surgeons. Both are credible. And if you're a member of one or both, you have to be board certified by the American Board of Plastic Surgery to be a member. So you look for that as well. So, with that being said, I think our time is done here. Again, I'm going to ask you if you like this content, you want more of this content. I love presenting it. Just subscribe. I can tell if you like it, you subscribe, you share, people talk about it, you make comments, and I'll make more. I have guests on. I've had two guests on so far. One in the official umbrella under plastic surgery TNA, Dr. Mike Kissel. We talked about weight loss and healthy lifestyle with the use of semaglutides and how that relates to plastic surgery if you have excess skin, if you want to go down that pathway. Beforehand, I talked about showing up as your best self after you've had plastic surgery with weight, before weight loss, or without any weight loss. You had plastic surgery and you improved yourself and you wanted to present your best self in your business, in your family. So I talked with a portrait photographer, branding photographer, Robin Stephenson. So you can look at that podcast video. And I like to have more guests and do more things, but that only comes with subscriptions to the channel so that I can grow the channel. So please take a moment, takes 2 seconds. If you think somebody might be interested, share it. Tell them to share it. It really helps me because I really do enjoy doing this and I want people to learn. So on that note, we're going to wrap it up. It's been a great Saturday. I hope you've enjoyed this. I hope you enjoy the rest of your Saturday. Stay safe wherever you are in the world. And we'll see you next Saturday with a special guest. I will hold that. Look for the advertisements this week. And I hope you join me next week at 11 a.m. Eastern Standard Time on Plastic Surgery TNA. I'm Dr. Earl Stephenson Jr. Peace.